All right, we're back, everybody, on a Medical Monday. Dr. Thomas Rauch is here with us, Advanced Health, Southern Sports Medicine Institute. He's got a great surgery center up in Hendersonville. We're going to talk more about the location and how you can contact him a little later on. But we're talking about knee replacement, specifically the new advancements in this technology, outpatient knee replacement, which is just fascinating. We're going to talk more about the doctor with that. We want to talk to you. 737+ is the phone number. We got some callers on hold. Let's go to line one. And oops, wrong one. Line one is Sondra. Hey, Sondra, you there?
I am. Thank you for taking my call.
You're welcome. Thank you for calling. How can we help?
After listening to this new procedure, that sounds amazing and fantastic and less invasive.
Yep.
My question is, will Medicare pay for it? And also, you know, if you have a supplement, that will kick in too. Or is it going to be considered experimental, and they're going to say poo-poo on it?
Well, thank you for calling, Sheila. Those are great questions. So every medical advance starts off as experimental. And this is something that has been being attempted for a number of years. Things have advanced with outpatient replacement now to the point where in certain locations, at specific centers, surgeons that are doing it using specific techniques and anesthesia and medications and whatnot, it's really not experimental anymore. In fact, one of the reasons that I wanted to wait to start talking about it was I wanted to have about 100 of them done as an outpatient first, just to make sure that it was working the way that I was hoping that it would. I did the first one a couple of years ago now, and then waited for a while before I did another, and then now it's got to the point now where we're doing it very routinely. So it's not experimental. Now, that's not the same thing as saying that everybody will pay for it. Right now, it's really only commercial insurers that are paying for it. And part of the reason is really political as much as it is anything. Medicare, the process for getting new procedures or new locations for Medicare to cover them is on a 2 or 3 year cycle.
That long?
So it just,
that long.
Yeah, there have to be public hearings and commentary and da-da-da. And so, so they're moving slow. But I will say that the conversation is going on, and it's something that is anticipated to be covered by Medicare within the next year or so.
Oh, sounds great. Thank you. Appreciate it.
Sure.
Sondra, thank you for calling. We appreciate it. And let's go to Jackie on line 2 now. Hi, Jackie.
Hi, how you doing?
Doing well. Thanks for calling. How can we help?
Yes, sir. I'm calling to see what material is used for the knee replacement, resurfacing, and is there any kind of rejection to the body? Because if there's anything put in there, then it would be probably, you know, considered like a foreign object.
Yeah.
Yep.
Body.
Boy, we got good questions so
really
far.
very,
All right,
very,
we'll
very
put
good
you on hold
questions.
here, Jackie, for a second and listen to the doc.
Yeah. So, Jackie, the materials are a combination of really 2 main materials. There is a metal component to it. These are made out of what we call super alloys. It's cobalt, chrome, vanadium, molybdenum. Basically, they're very, very high strength, lightweight metal alloys. But most importantly, they are not recognized by the body as anything particularly foreign. In the same way that your body's not going to reject a crown on a tooth or a filling, for example. There's also a very, very specialized plastic part to it that's made out of what's called an ultra-high molecular weight polyethylene, and now it's multiply cross-linked. It's basically all to say that it's processed in a way that makes it very, very durable. Now, the outpatient knee replacement, which really is a resurfacing procedure, is essentially the same as other knee replacements that I do for patients not as an outpatient. What's changed really that allows it to be done as an outpatient is the technique of getting it in. So using minimally invasive, muscle sparing, no tourniquet, avoiding the vessels so that there's very little bleeding associated. Long-acting medications, specific kinds of blocks in anesthesia.
Right.
This whole combination of things in medications and technique is what allows that same surgery to be done in a way that allows people to go home and walk on it right away. But the expectation is still that it will last every bit as long as any other knee replacement that we do.
Right. All right. Jackie, does that answer your question?
And I've never had anybody reject one that I've seen.
There you
go. It just doesn't seem to happen.
Yes, answer my question, but if I can make a small comment.
Yeah, go ahead.
Take up much time. Dr. Gauss, I have a rotary cup tear, and I was trying to pick a good doctor to workman's comp, and I did extensive research on you, your technology, the way you operate. I talked to several staffs in your office, and you're the one that I chose, the workman's comp. even though you was in the network, you was not on the panel.
Oh, I'm so sorry that I didn't get to see you.
I did opt out, and I will be coming to see you on my own because I was just totally impressed, and especially with your demeanor, because I did have some experiences that I wasn't quite happy with some of the doctors. So I'm really glad. I don't think it's no coincidence that I happened to sit down here and turn on the TV, and there you are.
Well, you're very kind. Thank you, and I'll look forward to seeing you.
Okay, now. Bye-bye.
Thank you. That brings up a really good question I was going to ask you, just about, patients coming to you. She mentioned your demeanor, and I know that you mentioned so many other people. It's a team effort,
it is
right,
a team
that you
effort.
work with. There are
Absolutely.
nurses and rehabilitative nurses, anesthesiologists is important, and so on. And every step of the way, you have someone coming in, and it's a nerve-wracking experience to have something like this done. This kind
Absolutely.
of
I've been a
procedure.
patient.
Yeah.
I've been a patient before, and I didn't particularly like it. Honestly,
right.
I don't like being on that side of it, but I remember it.
Yeah.
And and I've sat in waiting rooms, and I've been in an operating room on the receiving end, and so it's very, very important to me that that people gain a comfort level and really a trust level. I mean, that's the most important thing. If you can't trust your surgeon, you should not have them do your surgery.
Yeah, and you like callers like that or patients like that who come in already armed with some information. It may not always be the most accurate, but at least they've started to do their homework, and they can bring you the information, and you can easily, tell them, yes, this is correct information, this is not, and here's why.
Well, I love taking care of patients like that because a person who's invested in getting better has a much higher probability of getting better. I can do absolutely everything perfect.
Right.
And if a patient's not invested in getting better, that limits how good they're going to do.
Sure. Good point. All right, a lot of calls coming in. We really appreciate it. Let's go to Jeffrey on line 4. I keep hitting the wrong button. Sorry about that. Old habits are hard to break. Hey, Jeffrey, how are you?
Hello, can you hear me all right?
Yes, we can hear you great. What's on your mind?
Well, I have been honestly putting off this. I've been kind of dreading the scenario here.
Yeah.
Replacing my knee, and I was kind of wondering about how much work I'd have to miss and this and that. I had a hip replacement a couple of years ago, my left one, and I went through a time when that put me down. I wasn't able to work for 3 months.
Really?
Oh my goodness. Yeah, that's pretty tough. So, good questions. There's 2 ways that people will kind of go through knee replacement. The traditional course is a hospital stay, typically of 3 or 4 days, and then therapy, maybe in an outpatient setting, or maybe sometimes in a skilled facility or rehab facility, which you may have had a couple years ago when you had your hip replaced. And that's typically a 3-month or so process. What we've developed now is really a fast track for people who are good candidates for it, which basically means that their health is otherwise pretty good, they're highly motivated, still in pretty good shape, and not afraid to do the rehab that they need to. In that instance, people can come to our center, have a knee replacement, and basically stay at the center for about 4 hours, and then go home walking on it. Usually walking with a walker for 3 or 4 days, and that's it. Then maybe walking slow, and reaching out to touch something as they go for the first week or 2. Therapy typically goes on for about 5 or 6 weeks, and we're done. Most of the time, by the time we get somewhere in the 3rd or 4th week, people are doing better than they were before the surgery, both functionally and comfort-wise.
They can really feel the difference.
Driving at that point, so it's typically about half the length of recovery. Now, I wish I could tell you that you can have that surgery today and go skiing tomorrow. It's not true. We're not there yet. But it's substantially better.
Doctor, you said how soon after surgery? I would be so frightened as a patient to stand up and put any body weight. We
wouldn't have you do it on your own, right? So we've got therapists that are there helping you get up.
How soon after the surgery? You said a matter of hours.
Yep,
now,
hours.
To where you want them to get up and start using the walker to help you, obviously, but...
Right, so 2 major obstacles that prevented it in the past were that the kinds of anesthesia that we did would typically make the leg rubbery for a day or 2 and unusable. And the other thing is that pain was previously a major obstacle that you had to get over before you could even get up and start moving around.
Right.
And now with specific anesthetic techniques, we use ultrasound guidance to get right to the exact nerves that give you feeling it around the knee. Use very long-acting anesthetics, local anesthetics, that don't inhibit the function of the muscles, so that you can comfortably, literally get up put your full weight on this knee replacement.
So that part of it, the
surgery.
anesthetic advancements, that's huge.
That's
obviously.
huge part.
One of those obstacles that you talked
Right.
about in your job. What is there any kind of sedation during the procedure?
Yes.
Because personally, I wouldn't want to hear anything.
No, nobody does. Nobody. You just don't want to hear the tools.
Exactly.
You know, and the things that are
There's
going on.
some serious work going on.
So when we do that kind of block of the nerves, then we don't have to do as deep of an anesthetic.
Right.
Right. So you'll be unaware of what's going on,
just
but not,
mild,
but
to where
we
you
don't
can
have
come
to use
out
a
of it
deep
quicker.
anesthetic. Right. We don't have to use a deep anesthetic to prevent the pain and the feeling. Now, there's other things that go along with it too. So one of
that, in turn, I should say, is safer for the patient.
It is. That's
not
right.
Using the deeper
It is
anesthetic.
safer.
Okay.
So I do the surgery without using a tourniquet. So it used to be that you would march through the tissues, cut through the muscle and everything else, and then identify the bleeding when you were coming back out again and try and coagulate them as they go. Instead, I sneak around the vessels. So no major vessels are cut in the surgery the way that I do it. I also don't cut through any of the muscles or the ligaments. It's a sneaky way to get in, and that allows those tissues to stay still functional and usable and comfortable right after the surgery.
So with this new advancements, these new procedures, has anything surprised you? Do you still get surprised sometimes going into, or with the advancements, with your ultrasound, with everything ahead of time, when you go in, you pretty much are like, yep, this is just what I expected.
Well, I am
defined.
so I'm double-minded about it. As I said, I've done about 100 of them now outpatient.
Yeah.
It still does surprise me just a little bit to see people up walking around that soon after surgery, because I've been doing it for about 20 years now, you know. And so in the old days, you used to stay in the hospital for a week, and we didn't get people up for the first couple of days. So I know that it works. We've done it a bunch of times. Everybody at the center has the opportunity to stay overnight if they need to or want to. So far, in the first 100, nobody has. Everybody has gotten up and walked out.
That's remarkable.
And that still surprises me a little bit.
All right. A lot of calls on hold. We appreciate your patience. We're going to get to you. We've got to take another quick break here on Medical Mondays. We'll be back with your calls right after this.